Assalamualaikum warahmatullahi wabarakatuh and greetings to Dr. Shuhada. Okay, my name is Muhammad Shukri bin Muhammad Basari. My metric number is 277921 and I am first presenter of Group 1. We choose a topic about income equality and poverty, and we choose the factor of poverty is health factor in Somalia. Why we choose Somalia? Because we know Somalia is one of the poor country at Africa, and then it has a lot of issue about the health situation on that country, because we can see because it has a civil war, it has a poor of the, it has a poor of the country, as a limited source, limited of man ability. So because of that, the health in Somalia is really not good at all. Okay, so because of that, we choose that to we discuss. And then uh, in the part of introduction, I also will discuss about the what is the meaning of income equity, poverty, and we can see income equity is referred to the lack of equity, balance of similarity between two or more people, which can be measured through the reading data and economic indicators such as SDG, Sustainable Development Goal. Then we can see one of the goal is health. And then what is mean of income is can be defined as a salary, and then poverty is man inability to meet income line by the government, which is cover needs such as food or not food, because some sector, some people do not reach the line of the poverty in some of country, for example in Somalia. Because of that, we categorize that Somalia is still a poor country on the factor of health. So um, these studies or this research will talk about what is the policy that be implemented and been done by the Somalia government, and then we can see whether this policy is well done or not, and what are the factor involved to done in this policy, and why the policies not being done in a good way in the Somalia, and it still makes Somalia is still poor country or poverty in health situation. And then the research we all as a researcher also will discuss about the comparison of health policy in Malaysia and Somalia, and what health policy in Malaysia can be applied in Somalia country. And then why this discussion is really important, because we want to see what are the best way we can make Somalia from the poor of health become increase or decrease poor uh, in a health sector. And then we also I will give one or two suggestions that can be done or implemented by the government of Somalia to reducing the poor or poverty in health sector in this country. And lastly, we all will conclude this discussion is done in a good way or not, and we can see what is the issue, what is the factor of income inequality and poverty in health sector in Somalia. So I will pass to the next presenter. Thank you.
Assalamualaikum and good day. My name is Muhammad Arabian Nasri, matric number 279358. So for today, I will explain briefly about the background of the country that we choose, that is Somalia. Somalia is a country located in sub-Saharan Africa. The region is one of the land scarce regions in Africa, causing many countries in the region to experience drought, poverty and famine. However, one of the countries with the worst level of poverty and hunger is Somalia. Although as many as 6.7 million Somalis began to recover from the drought experience over the past few years in early 2017, this did not end poverty in Somalia, evidenced by the fact that there are still a large number of Somalis living in the poverty. Poverty in Somalia has a huge impact on the entire local economy, especially in the health sector. The backward health sector in Somalia has caused the country to experience various crises that could threaten the lives of the people. The level of health in Somalia is currently seen as an increasingly worrying due to the lack of equipment and sufficient manpower to ensure the health of every citizen is guaranteed. It is said that so because Somalia is a less developed country and has underdeveloped infrastructure. Health indicator in Somalia are among the lowest in the world. In Somalia, as the case with the least developed country, health and development indicator have hardly experienced any improvement. So in Somalia at present, there are 196 medical center, health, MCH clinic and outpatient dispensaries, and 520 health posts that provide preventive and outpatient curative service mostly to the urban population. For many areas in a rural district, its services are limited, which makes its use seem irrelevant to the needs of population, although there are variations in their capacity. Most of these facilities has been crippled by the ongoing civil war and unrest. There are several factors that contribute to the deteriorating levels of health in Somalia. The first one is the lack of graduates in medicine. The human resource crisis for healthcare in sub-Saharan Africa has left the health sector underdeveloped. It is estimated that each year only 10,000 to 11,000 medical students graduate from the region. This suggests this lowest number is directly tied to the lack of medical schools. Medical schools in Somalia are said to lack an effective workforce, resulting in a shortage of graduates in medicine. The maintenance cost of establishing a medical school in Somalia is so high that the learning process cannot be carried out properly. The unstable economy in Somalia also has made the opportunity to produce a medical generation increasingly limited. Next is the migration factor of medical field workers. Somali-born physicians have mostly migrated from the low-income country in sub-Saharan Africa to high-income country in North America and Europe. This pattern of migration has reduced the medical workforce in some areas. Motivating factors identified by immigrant healthcare workers including low wage, poor work environment, poorly protected health care facility, and lack of opportunity for career advancement. Moreover, there is strong correlation between political instability in a country and the loss of medical staff. Attractive factors for migration include higher salaries, better health care facility, and more opportunity for career advancement. The Somali government should limit the migration of healthcare workers from Saharan Africa by minimizing the influence of both push and pull factors.
My name is Nur Azura binti Harude. My metric number is 278732. In this discussion, we will explain about the human resource development policy in Somalia health system from 2016 until 2021 and the policy taken by the government during COVID-19. Firstly, the formulation of the human resources for HRH development policy is an important method that provides an opportunity to develop an important component of this health system in Somalia. The policy aims to build national consensus on the critical role of the workforce in improving the performance of the health system and to encourage health professionals and health sectors stakeholders to jointly address HRH issues. In this policy, it involves a lot of policies intervention. The first policy intervention is human resource production and training. Second is the planning, use, development, and management of HRH. Third is HRH financing and diversification of funding sources. And the fourth policy intervention is to establish mechanism for HRH retention. Next, policy taken during COVID-19 is the Somalia government uses a phased approach consisting of population of components and health system components. The component is a general population awareness campaign on transmission and prevention routes. So the population is well informed about how to respond to clinical symptoms. The government banned public meetings and closed schools and universities. Other than that, Somalia airport were closed. However, the disease prevention and control strategies pursued by Somalia are not strict compared to the lockdown implemented in other countries.
Next is the achievement and program implemented in Malaysia that can be practiced by Somalia to overcome health problems. There are various initiatives and achievements made by Malaysia in improving the level of public health. Among them is the idea of establishing a One Malaysia rural clinic, which is officiated by the fourth Prime Minister of Malaysia, Datuk Seri Najib Tun Abdul Razak on 7 January 2010, equivalent to the One Malaysia concept at that time. There are 50 clinics that have been built at a cost of RM10 billion. The opening of One Malaysia clinic is a clear effort by the government toward low-income people to make it easier for them to get treatment and medicine, but only charging RM to RM1 to each Malaysian citizen. The initiative has been successfully implemented to alleviate the burden of Malaysians to indirectly ensure that the health of Malaysians. Somalia can also practice this method introduced by the Ministry of Health Malaysia through the establishing of this One Malaysia clinic. The Ministry of Health in Somalia can set up a rural clinic equipped with a simple medical equipment to the people to enable them to receive the treatment they need so that the level of health is more secure. Through this initiative, the government in Somalia can offer employment opportunity to the medical community to meet the capacity of each medical center built to reduce poverty in the country can entirely ensure the health of the entire community in Somalia. Apart from that, the health community of Nation Builders program is also one of the intervention of the Ministry of Health in Malaysia is an effort to curb the problem of infection disease. The implementation of the program is through the several effective approach to the establishment of functional units consisting of volunteers from the community in Malaysia who act as volunteers. This group of volunteers play a role in helping the front line to prevent the spread of this infectious disease. For example, at present, Malaysia is still under the threat of the dangerous COVID-19. Therefore, the government is organizing a vaccination program for all Malaysians to reduce the risk of contracting this infectious disease. This shows that this program is able to increase the level of immunity of the community in Malaysia. In addition, Somali government can also establish diplomatic relations with Malaysia, especially in the field of medicine. As an analogy, Somalia can send a medical representative to study medicine in Malaysia until they can become proficient in a certain period before being back to their origin of country to practice the medical skill learned to the people of Somalia. This can indirectly increase the very high productivity rate in medical field and can reduce the income inequality and poverty that flood the country of Somalia.
There are two suggestions to improve health system in Somalia. First, the Somalia government needs to address the need to increase the short-term capacity of the health workforce through service training and long-term strategies aimed to improving the quality of the health workforce in Somalia. Second, the Somalia government needs to introduce online distance learning opportunities in collaboration with local academic institution and health sector partner organisation. Third, strengthen cooperation and build partnership among different stakeholders at the national and international levels.
Assalamualaikum warahmatullahi wabarakatuh. My name is Nimok Faiz bin Faizo, matric number 279740. I will present about conclusion. For conclusion, we can see that through this Sustainable Development Goals (SDG) framework, it has shown that Somalia is one of the poorest countries in Africa. This is because their country is often involved in civil wars and unstable political turmoil. We also can see that the discussion is about background, factors, policy, achievement, and program that relevant with the health issue in Somalia. Through this discussion, we can conclude that this problem at Somalia actually can be overcome if the government of the country works so hard to curb the problem of income inequality and poverty that occurs in their country by providing more effective policy or by following the policy of the countries that have achieved in terms of health. This will indirectly affect various aspects such as the country and society, where the country can achieve a good level of national health and society also can live a fit and healthy. Okay, I think that's all from me. Thank you.